Bismillahirrahmanirrahim. Assalamualaikum and a very good morning to everyone. This morning we have a very interesting topic to discuss and also to present to you. The topic this morning is the role of ultrasonography in the management of snake-related injuries, in particular for snake envenoming. So this morning we have 3 speakers. On top of that, we have 2 moderators that will be moderating our forum later. So the first speaker I would like to introduce to you is Dr. Yang Mao, who is our moderator number 1. Dr. Yang is based in Taiwan. He is actually the assistant professor in the Division of Clinical Toxicology, Department of Emergency Medicine, Taichung Veterans General Hospital, Taichung, Taiwan. He has a special interest in clinical toxicology and toxinology. The next moderator is Dr. Reza Murad Kamarudin. He is the Emergency and Trauma from Emergency and Trauma Department in Melaka General Hospital in Malaysia, and he also has a special interest in clinical toxicology and emergency medicine. Our first speaker will be Dr. Muhammad Shukruddin Saleh. He is the consultant in the Emergency and Trauma Department of Hospital Sultan Ismail Petra in Kuala Krai, Kelantan, Malaysia. He is the current head of department and also emergency physician, and his special interest is in clinical toxinology, critical care, and emergency ultrasound. Following Dr. Shukruddin's presentation, we will have a second speaker, which is Dr. Ruth Sabrina Safari. She's a consultant emergency physician from the Emergency and Trauma Department of Raja Permaisuri Bainun Hospital in Ipoh, Perak, Malaysia. Her special interest is in clinical toxicology and toxinology, and also CBRNE training. Finally, our third speaker and final speaker from Taiwan is Dr. Cheng Xuan Ho. He is the emergency clinical physician in the Department of Emergency Medicine, Tri-Service General Hospital in Taipei, Taiwan. And his clinical special interest is in clinical toxicology, chemical injury, and sonography. You can find all of our moderators and speakers' biodata in our Facebook post. And this is actually a collaborative effort from the Emergency Department of UKM and also the Malaysian Society on Toxinology and Remote Envenoming Consultancy Services, or RECS. So without further delay, I would like to invite our first speaker this morning, Dr. Shukruddin Saleh, for his talk. So please welcome Dr. Shukruddin.
Thank you very much, Dr. Professor Khaldun. Assalamualaikum and hi everyone. I'm Dr. Muhammad Shukruddin bin Saleh, emergency physician from Hospital Sultan Ismail Petra, Kuala Krai, Kelantan, Malaysia. And the topic I will discuss and share with you all this morning is regarding snakebite related injuries, clinical features of envenoming, and red flags of misdiagnosis. Okay, the objectives of our presentation is to understand the local envenoming effect of snakebite envenoming, which should be known as envenoming syndrome, to understand the usual progress of envenoming syndrome and the local envenoming effect of certain snake species, especially the Naja species that we saw in our country, which is causing significant dermal necrosis or tissue necrosis, And also we discuss the common misconception in clinical management of snake bite patient. Okay, first we have to know that the cases that I shared has its limitation, because the cases discuss mainly what we the remote envenomation consultation service in Malaysia, so and have to manage cases in Malaysia. In terms of local envenoming issue or effect, mainly it involves the cobra, the two cobra, the Naja cautia and Naja sumatrana, Salosalasma rhodostoma, and also some of the Trimeresurus complex species. And we have to know that different region of the world have different snake species which has different clinical envenoming effects. So our main things to discuss within my context of presentation is the local envenoming effect following a snake bite that is caused by the cytotoxic snake venom, which causes severe pain, progressive swelling and edema, local tissue necrosis, which manifests as blisters, bullae, inflammation, also pus formation. This is an example of cases we saw within a few hours. There's a formation of blue purplish discoloration of the skin, usually because of Naja species cytotoxic venom, which causes swelling, pain, and also progressive soft tissue damage. As we can see, within 2 days, the actual extent of the necrosis has extended, and by 4 to 5 days, the usual progression that we saw will be inflammation of the surrounding skin of the necrotic tissue. And this is actually expected, not because of infection. And because of these changes, the managing doctors can confuse it with infective necrotizing fasciitis. And for this patient, this 7-year-old boy received 10 vials of Naja cautia antivenom, and by day 7, excision of the necrotic, debridement of the necrotic tissue was done, and mainly the tissue that were damaged, mainly in the soft tissue of the skin, do not involve the muscle layers. This is another example of a typical Naja species dermonecrosis, which causes quite extensive tissue damage to the patient, causes morbidity to the patient. And this is the final outcome of the quite severe local envenomation effect of the skin of the patient. This is just to share some example cases that we saw. Next is an envenomation with local envenoming effect due to Salosalasma rhodostoma, or the Malayan pit viper, that we saw usually affecting the northern part of the peninsular Malaysia. As we can see, by 8 hours, that we can see some formation of hemorrhagic blisters start forming. And even within 26 hours, this is the extent of hemorrhagic bullae that was seen in this patient because of the significant cytotoxic venom effect of the snake. And this is before and after aspiration was done. And usually when blisters formation in patient with dermonecrosis, we advise the managing doctors to send culture and sensitivity from the aspirated fluid. And this is the progress of the patient by day 8, quite good healing. This is because the patient received 3 vials of Malayan pit viper antivenom 2.5 hours post-bite. Because of local and also systemic envenomation effect. The patient had a quite early manifestation of coagulopathy in his blood results. So this is the progress by day 8 post-bite. just a minimal soft tissue loss for this patient, and no surgical intervention was required. Bear in mind that this patient also having significant swelling, progressive swelling, and also painful limb during the few days he was admitted to the ward. But fasciotomy was not done for the patient because the clinical problem of the patient is envenoming syndrome, and it is not because of compartment syndrome. This is another, occasionally we saw a patient who presented with a mangrove pit viper envenomation, which if it involves digit can cause significant necrosis of the digits. So in our country, the local tissue necrosis that we saw usually affecting the cobra, either it's Naja sumatrana, the common causes, and also Naja cautia. And occasionally we saw some form of local tissue necrosis involving the Trimeresurus complex species. So why the patient have, in managing a patient with local envenoming effect, you have to know why the patient develops progressive swelling, severe pain, and also tissue necrosis. Okay, this is because snake venom has a lot of mixture of proteins, enzyme, and substance that is toxic and lethal to the prey, which the main purpose is to immobilize the prey and also to start digestion of the prey even before the snake swallow the prey. That's why we are seeing a lot of tissue necrosis involving especially the cobra cytotoxic venom effect to the bitten limb. And there are a lot of factors, there are a lot of content of the snake venom, which is non-enzymatic toxins and also enzymatic toxins, which causes damage to the soft tissue of the patient. So what we are seeing is not primarily because of infection that occurs following a bite by a cytotoxic venom of the Naja species snake, but it is mainly because of this effect of cytotoxic venom. And even the venom have a digestive hydrolases that digested the soft tissue of the patient. So this is just to share. I have to be very quick because of time constraint. I have to finish 40 slides of my presentation. So I have to a bit rushed. Okay. So a common pitfall that we saw in management of snake bite patient is clinician usually always over-diagnosing compartment syndrome, and the diagnosis was done clinically. Why this all happened? So we have to understand why the patient is having severe progressive pain, progressive swelling, and also local tissue necrosis. So we have to understand that the venom causes superficial edema and increases the subcutaneous tissue pressure that often actually it mimics compartment syndrome. It's not actually a significant elevation of the compartment pressure. And the damage seen, as we are seeing currently in our country, the degree of damage if the patient was bitten by Naja species snakes, usually at the skin level, and very rarely it causes significant amount of myonecrosis. But in other part of the world, we may have saw a different clinical pattern of damage because of the cytotoxic venom effect involving pit vipers envenomation, which is rarely seen in Malaysia. So the treating doctor starts to thinking of impending compartment syndrome, which is clinical diagnosis when the patient has a numbness of the bitten limb, pain out of proportion to the apparent injury, pain of passive stretch of the muscle within the compartment, tenseness of the compartment on the palpation, and also weakness of the involved muscles. So the working diagnosis will be impending compartment syndrome. But it is actually envenoming syndrome because of the cytotoxic venom effect. The numbness can be because of direct cytotoxic effect of the venom. Pain is not because of ischemic pain that we saw in classical traumatic compartment syndrome. The pain is actually from direct effect of the cytotoxic venom. And pain on passive stretch of the muscle is also because of the cytotoxic venom effect. Even a patient bitten by a bee or a centipede over the limbs, any movement of the limb will cause pain, and that is not because of ischemic pain. That is because of the direct venom effect to the patient's nerve. And tenseness of the compartment. Majority of the swelling that's affecting the bitten limb by a Naja species in our country is because of the soft tissue swelling. And if ultrasound is done, usually it just shows majority of the swelling of the skin layer of the patient, and occasionally some form of muscle edema. And the limited movement because of severe pain the patient is experiencing, and it is not because of the loss of nerve function. And usually fasciotomy is not indicated in envenoming syndrome that we saw in our country. So why we are worried of diagnosing impending compartment syndrome? Because the implication of fasciotomy that follows the diagnosis. So this is the effect of doing fasciotomy to a bitten limb in a snake bite patient. As we can see, the level of injury that we are doing to the injured limb, and how long the healing process of the patient will take. Additional for the patient have to endure. Okay, because it is mainly diagnosing clinically without proper measurement of the compartment pressure is not justified. And in our consultation group, we have in many occasions has managed to discourage managing doctors from performing fasciotomy, and the more clinical parameters should be assessed when deciding for the best management plan for the patient. Okay, so we are seeing a lot of patients who was bitten by a venomous snake, developed progressive swelling of the limb. In our database of cases, there are quite a lot of cases bitten over the hand, the swelling progress up to the shoulder, even to the chest, with the typical signs and symptoms mimicking compartment syndrome. And majority of the patients do not undergone fasciotomy because this is actually envenoming syndrome. As we can see, for example, for this patient, you can barely see the ankle joint because of the massive swelling, and this patient do not undergo fasciotomy. And the only surgical needed is to debride this necrotic tissue. There are a few literatures that commented regarding controversy regarding fasciotomy, performing fasciotomy in snake bite patient, and with currently availability of a modern and safer antivenom, it should be the first line of management and treatment for the patient with significant local envenoming effect. Okay, an article published in Toxins, where the author commented that because of lack of knowledge by the doctors, that confuse between envenoming syndrome and also between envenoming syndrome and compartment syndrome, and cannot differentiate the difference between what have the pathophysiology of the snake bite induced swelling from the classical traumatic compartment syndrome. It will affect the management plan of the treating doctors. Okay, even not only in our country, even in the American that was reported by the Californian Poison Center, out of 28 cases that they studied from 2001 until 2012, fasciotomy was performed in 28 cases. Only 2 cases actually had their compartment pressure measurement done, which means the majority of the cases that was done fasciotomy was based on clinical assessment and not by evidence of the compartment pressure. Okay, another issue, what is the pressure cutoff point? Based on WHO Southeast Asia guideline of snake bite, it is stated that that is at 40 millimeter mercury. Another issue is how accurate is the measurement done toward the swollen limb. There's an article published by the Turkish team. They state that they are using algorithm that use 55 millimeter mercury of compartment pressure as the cutoff point for indication of fasciotomy. Okay, in our country, currently based on our clinical practice guideline, the monitoring that we advise patient when monitoring patient with envenoming of the local envenoming effect of snake bite is monitoring the progressive local envenoming effect of RPP. We call it RPP, the rate of proximal progression of swelling. This will be elaborated by Dr. Sabrina afterward. The pain score progression, the serial assessment of the pain, serial features of the demo necrosis. Taking serial pictures is very helpful in making decision. And also we see that total white cell count, serial total white cell count and creatinine kinase is very helpful in part of our decision making regarding the patient's management. Okay, monitoring the local envenoming effect. What we are interested is looking at the speed of the swelling. So speed meaning how fast the progression of swelling, how many cm in how many hours. So if observation was done at a fixed interval of 2 or 3 or 4 hours, the progression of swelling will give some clinical clues of how bad is the local envenomation is occurring at the patient's limb. Traditionally, what was done is measuring the girth or circumference of the bitten limb, which is, for us, it is clinically unhelpful in making decision of management of the bitten limb. This is an example of patient bitten by a king cobra or Ophiophagus hana, admitted to the ICU. He received 30 vials, a total of 30 vials of king cobra antivenom. Okay. Another issue is when to intervene surgically. Another diagnosis that commonly arises for patient with local envenoming effect with dermonecrosis is necrotizing fasciitis. Is it truly the damage that we are seeing because of the primary infection of the bacteria? Is it secondary, or is it mainly opportunistic infection because of there is already a necrotic tissue available for the bacteria to survive? And we have to understand the stages of wound healing in patient in dermonecrosis. Pus formation is expected in Naja species dermonecrosis. Pus is not necessarily mean that there's active infection is ongoing. This is because of the necrotic tissue degraded, damaged by the cytotoxic venom becomes degraded. And inflammation is also expected part of the healing process of the dermonecrosis. And in Naja species dermonecrosis in Malaysia, the pattern that we are seeing, the expected progression is within hours, early bluish purplish discoloration of the skin associated with progressive swelling of the soft tissue, and occasionally with muscle edema, depending on where the bite occurs. Within 48 to 72 hours, formation of blisters, which is quite common, which may become bullae. And this becomes a very good source of culture and sensitivity to guide the antibiotic usage. By day 4 to day 5, inflammation of the surrounding injured skin, inflammation is expected. And then formation of pus, the wound area becomes demarcated. And this is roughly as an estimation based on cases that we saw in our country. Just to share a case that when surgical intervention was done too early, this is less than 24 hours of the bite, formation of tissue necrosis, but it is not well demarcated yet. Debridement was done quite early, 26 hours post-bite. And after the debridement, povidone dressing was applied to the limb. So as we know, povidone has a cytotoxic effect to the skin, and the injured tissue surrounding the necrotic area will become damaged. Together with the post-op bandaging, this compression will further reduce perfusion to the injured tissue of the skin. And this patient also, fasciotomy was done because of the swelling and all the signs and symptoms that mimic the compartment syndrome. So debridement needs to be done again because it is not well demarcated yet and it is done too early. This is another example where the injured tissue is allowed ample time to recover, where debridement was done only after 9 days of patient was bitten by the snake. And this patient received a total of 15 vials of Naja cautia antivenom. This is the culprit. As you can see, the monocellular, the O-ring at the ventral part of the snake, bitten over the hand. It is a provoked bite. So the patient developed swelling that progressed up to his shoulder, and he developed blisters as expected, blisters, inflammation, and no fasciotomy was done. He was covered with broad spectrum antibiotic, and our team waited until we allow the tissue to recover from the cytotoxic venom injury before going in for debridement. And sorry, I don't have the picture where post-op wound, but only have 2 months later. This is the level of damage recovery that the patient undergone. The patient refused skin grafting, so he was managed by our wound team, and the recovery is quite good. So necrotizing fasciitis, it is a rare bacterial infection that can cause death. And when you Google necrotizing fasciitis, usually the flesh-eating disease will come up, death will come up, infection come up. So this is why we are worried, and early intervention is thought of to manage the patient. However, effective necrotizing fasciitis has different surgical approach. If it is an infective necrotizing fasciitis, then yes, it requires early debridement and extensive infected tissue should be debrided. But in snakebite dermonecrosis, debridement should only be done when the extent of damage has already well defined. And we need to allow for the injured surrounding tissue to recover to its maximum potential and avoid cytotoxic povidone dressing and also bandaging that interferes with perfusion that usually associated with early surgical intervention. And even the debridement should be more conservative compared to the effective component of effective necrotizing fasciitis. So the managing doctors need to understand the expected progression of dermonecrosis wound healing process and serial infection markers of temperature, clinical feeling of the patient, total white cell count, serial total white cell count, and also creatinine kinase is important. So two common diagnoses that we suggest should be less use of diagnosing impending compartment syndrome, and we should change it to the envenoming syndrome because of two different approach and understanding of the pathophysiology. And necrotizing fasciitis should be diagnosed as venom dermonecrosis because it is not a true effective necrotizing fasciitis, but all the tissue damage or tissue necrosis is primarily because of the venom effect to the tissue due to the cytotoxic venom effect. So in conclusion, managing snakebite victim is very challenging. And we have to use a correct diagnosis because correct diagnosis will affect our management plan and outcome of the patient. And lastly, surgical intervention has its role in managing local envenoming effect of snakebite, especially dermonecrosis, but most of the time it is not in early part of envenoming. That's why in our country, the primary team that managing snakebite patient is our medical colleague. However, as I understand, in certain part of the world, the primary managing team is fall to our orthopedic colleague. And lastly, expert consultation may help in having a better outcome of the patient. I think that's all for my topic. Thank you.
Thank you, Dr. Shukruddin. That was a very, very interesting presentation and very graphic as well. As you can see, the extent of damage that can happen if somebody got bitten by a snake, venomous snake. It can be from the Naja species that we can see in Malaysia, and also some of the pit vipers. Not all pit vipers, but some of the one which has higher cytotoxic effect. Yeah, so that gives us a bit of baseline or background of where we're going next with our second presenter. So the next speaker is Dr. Ruth Sabrina Safari. She's emergency physician, and she will be talking a bit more about the method of monitoring for snake envenoming. So Dr. Sabrina, whenever you're ready, the mic is yours. Thank you.
Assalamualaikum and a very good afternoon to all of the participants and also panelists, so moderators. So it is a pleasure for me to actually not to teach, but rather to actually share the information that I have regarding this topic of documenting the rate of proximal progression, how sonography helps. Okay. Okay, so Dr. Shukruddin has actually explained prior regarding the need for us to know the pathophysiology of local envenomation in snake bite, whereby it's actually quite different compared to the pathophysiology of compartment syndrome in trauma, whereby the venom effect is because of the tissue inflammation causing subcutaneous edema and etc. So a bit of recapitulation of what Dr. Shu has already mentioned regarding the parameters to measure in local envenomation. So we have a few parameters to measure if a patient is bitten by a snake that presented to us with local envenomation, which is the first one is a pain score of progression, which we can measure during by a few measuring methods, depends on the patient's age. For example, the visual analog scales and etc. The next one is RPP that we will discuss further. The next one is worsening of a local tissue necrosis, which we can actually measure by actually serial pictures of the wound over a period of time. But of course, consent may be needed in view of taking the pictures. And also measurement of the and also observation of the blister and bullae formation, especially hemorrhagic bullae, and also palpation of the tender draining lymph node over the affected site of the bitten limb. And also do not forget to actually measure the circulation adequacy by actually check the patient's perfusion, make sure the pulse is palpable, and so on. So which technique does a clinician prefer to evaluate swelling in local envenomation? So we personally, I have actually applied all these techniques before, which is number one, the naked eye observations, meaning that you use fully your eyes to observe the patients over a severe period of time. This may have the pitfalls as well, because sometimes in a very busy emergency departments or in the ward, we might forget the level of swelling, for example. So this is more of subjective technique, I would say. And the second one is the serial pictures, whereby the best angle to take is the same angle of the picture that we take for the bitten side. And the third one is the circumferential girth. Okay, this is the most used techniques so far in Malaysia, but I'm not sure in other parts of the world how it is done. Which actually the circumferential girth is measured at multiple levels, whether it is actually in the upper limbs or the lower limbs, it depends on the bitten side. And there are not actually no definite landmarks. And also, of course, the next techniques is the RPP. So what is actually RPP? So basically, RPP stands for rate of proximal progression of the swelling. So RPP is actually mentioned in our CPG guideline of Malaysian snakebite management that had already out since 2017. So it basically measures the rate of proximal progression of the swelling over a period of time, and it is measured in a centimeter per hour measurement. So let's say in this picture, what we'll see is that the patient is being bitten, example at the PO, and patient can come to emergency department at 7 o'clock, whereby the rate of proximal progression was started from the patient, from the start, from the time the patient presented to emergency department, for example, the 7 o'clock or 90 hours. So this is the level of the proximal swelling that a clinician can actually observe. So it was actually being taped, the limb is actually being taped by the micropore and labeled with time and preferably the date. And in initial snakebite management patient, normally we will measure the RPP, closer measurement of the RPP, let's say hourly first, because we need to determine whether the patient will need antivenom or not, especially if the patient being bitten by the snakes, confirmed snakes that can cause local tissue cytotoxicity, for example, vipers or cobras. Like in this picture, we can see the next RPP be measured about 4 hours later, and the next swelling that the clinicians actually can measure is at this point. So another micropore was taped at this point. So the measurement is taken from the distal part of the micropore until the distal part of the micropore. So it's measured over here until here about 2.5 centimeter. So we count the RPP as 2.5 centimeter divided by 4 hours. So it will be about 0.6 centimeter per hours. And then we will actually measure again the RPP for the next hours and see whether the rate of proximal progression is actually increasing or static, or actually not increasing. So this is basically how the RPP is measured manually. So by right, the labels, if you can see here, there are multiple labels of micropore being put here. By right, if we have already measured the RPP and documented in a snakebite chart, so the most distal part of the micropore should be taken out because it can precipitate bullae formation if the patient allergic to the micropore, or it can actually stick on to the monocyte, which can be bad for the management of the monocytes later on. So this is the example of the snakebite charting and the RPP column. So most of the time, when we are consulted regarding the snakebite cases, the RPP column is either being dashed because most likely the person do not measure it, or being measured but incorrectly, meaning that the person actually do not measure it in centimeter per hour. So this is just another explanation of how the RPP of the edema is being measured. So I have explained it before. So why measuring rate of proximal progression is important in snakebite? So because of two reasons, it will determine the need of the antivenom if the RPP is consistently increasing at the same or increased rate. And the second one is it will determine whether the previous antivenom given was effective or we need to top up with another dose of the antivenom, right? And of course, when we talk about RPP, we cannot actually interpret the RPP single-handedly. Rather, we should actually interpret the RPP measurement with other local tissue swelling assessment, local tissue, local envenomation assessment. For example, the pain score progressions and etc. that I've mentioned before. And still measurement is the keyword. Normally, when the patient is in emergency department, it will be measured. But once the patient in the ward, it's a bit difficult because there are so many patients and we tend to forget about the patients. Okay, so RPP, can ultrasound help? So based on the guideline of snakebite, again, by the Ministry of Health in Malaysia, it is mentioned in point number 5, page number 48, that the ultrasound can be used to more accurately determine the extent of tissue edema, and it is seen on ultrasound as a cobblestone sign. Actually, there are a few signs that we can see from the ultrasound. So basically, if our emergency department have ultrasound, so we can actually measure the RPP by using it. So, but you need to have a certain things. Okay. So first of all, the transducer that we need to use is the linear array probe transducer with a high frequency, about 7 to 12 millihertz, and this is the view that you can see from your ultrasound machine. Okay. Why we use the high frequency is because we want to see the superficial tissues, so it can enhance it. So the one that we can measure is or adjust the gain, the depth, and also the focal zone. And of course, when using a linear array probe or any other probe, so you must orientate yourself. So when the marker dot should be at the patient's kipholet or the patient's right of to the patient's right. Okay, so this is the example of the marker dots, right? And other thing, and remember, in measurement of the RPP using the ultrasound, you may need to actually compare it with the normal limb, and also after that, you will actually do it on the abnormal limb or the beaten limb. Right. So this is one of our colleagues from Taiwan's paper that highlight the overview of point of care ultrasound for soft tissue and musculoskeletal application in emergency department, whereby actually the image can be enhanced by using certain methods. In a patient who was bitten at the fingers or the toes, for example, sometimes to do the ultrasounds of the soft tissue, it can be a very difficult situation. So we have to have certain methods to enhance it. So for example, in this picture, the ultrasound was done in a water tank so that it would enhance the things that they want to see, which is actually the coin. For example, in this study, is a coin, right? So same, that is the principle. So for example, the previous ultrasound, if you want to enhance it, we put a gel on top of it. We go for the normal anatomy of the ultrasound of soft tissue. If we put the probe on the normal leg of the patient, normal upper limbs or lower limbs of the patient, so this is the normal anatomy that you should actually see, which is the number one is the layer of the epidermis and dermis, and number two is the layer of the subcutaneous fat, which is actually not too hyperechoic, okay. And number third, you may see blood vessels. This is in transverse view. And number four is the muscle. You can see a striated muscle here. And the fascia line over here, that is not actually numbered. And the fifth one is the bony cortex. Okay, right. So what are the signs to look for in ultrasound of the soft tissue in snake bite? So basically, we are looking of two particular signs if you want to measure the RPP using the ultrasound, which is the first one, soft tissue edema. Often is actually initial signs that we can see, and second one is a cobblestone sign, which can be seen a bit later on. Of course, the signs is not specific. For example, if the patient is already been bitten by a snake bite, and on top of that, she also have got, for example, CCF with overloaded symptoms. So this might possess a difficulties for us to assess by using the ultrasound. How can we translate the signs into measuring the RPP? Okay. So we shall seek for the most proximal sign and mark it as per RPP reading. Means that we seek for the most proximal sign of soft tissue edema or cobblestone appearance sign, and we see where the signs actually stop, and we mark it and we measure it. And it is a severe measurement. And additional value is that using ultrasound also, if you have got the Doppler, you can also measure the Doppler too, but this will be highlighted further in the next presentation. Okay. This is the example of the soft tissue edema image that we can see from the ultrasound. So in the left corner, we can see this is a normal subcutaneous tissue where there's no hyperechoic changes seen. So this is the soft tissue edema seen. This is the fascia plane. And we can see that there are hyperechoic changes over here. Not so much of cobblestone appearance because this is too the changes is early, right? So this is what we call soft tissue edema. So next one is the popular articles that actually written by Vohra et al. From California, USA, whereby they are conducting prospective observational study on the rattlesnake envenomation. So 13 patients were enrolled, whereby they are analyzing the sonographic signs of snake bite in a patient bitten by a rattlesnake. So they find out that the most common sonography findings was subcutaneous tissue edema. And the edema and necrosis is found in 3 patients with rapid progression of leg swelling that spared the deep muscle layers and the facial plane. So they conclude that the ultrasound imaging may allow for more complete understanding, of course, and they also were able to document normal deeper muscle integrity in cases with diffuse leg edema. So as been mentioned by the first speaker before. We go to the next sign, which is the cobblestone appearance sign. this is the example of the tibia of the patient. This is normal. This is an abnormal leg. You can see there's a fat globules with with a fluid collection. You can see we call it a cobblestone appearance sign. And this is other images that highlighted about the cobblestone appearance. So because there are edema of the subcutaneous tissue that actually worse that it can separate the fat globules over the subcutaneous tissue region. So we can see it as a cobblestone, yeah. And underneath is the fascia and also the muscle layer. In a case report by Jolison et al. From Baltimore, they reported a case of snakebite patient, unidentified snakebite actually, 36-year-old Malaysian, 36-year-old gentleman, which actually bitten by an unidentified snake. Presented with local tissue swelling, where they did the ultrasound on the lateral left foot, and they found out that there's a soft tissue edema with fluid collection, and also those highlight here is the extensor tendon, whereby the patient has actually suffered from a tendonitis as well. So there is a letter to the editor as well to describe regarding the sonography of snake bites from the Thailand researchers, and they actually emphasize those literature review that they have read from the previous studies that been done. And of course, this is again a study from our colleague in Taiwan that conducted descriptive studies about snakebite patients in northern Taiwan from 2009 until 2016, whereby their most cases of snakebite is actually being bitten by the brown spotted pit viper and also bamboo pit viper. And snake bites, especially those by brown spotted pit viper, induce severe soft tissue swelling, which can mimic compartment syndrome. But it's certainly not exactly compartment syndrome. And this is the highlighted features when our colleague do the ultrasound of a patient. And again, there are soft tissue edema that can be documented over here, right? And of course, our colleague also measure the Doppler flow as well. So will be described further after this. So the question is, any study of using ultrasound for measurement of RPP in snakebite cases nowadays? So of course, if you ask in Malaysia, there are no study done yet. But I've tried to search for the other studies in the literature. So it seems that in a BMJ journal, our colleagues from the South Africa actually has described the ultrasound findings in a 42 patient with cytotoxic tissue damage following bitten by a South African snake. And what they found is that there are 42 patients enrolled, and they found that the envenom limb of each patient was scanned to the point of maximal swelling, and it was compared with the unaffected limb. And they are comparing the expansion coefficient, whereby they actually measure the ratio of the thickness of the tissue structure, which is actually measurement of the subcutaneous tissue and also a muscle compartment. So in the envenom limb comparing to that of the unaffected limb. So they found out that the conclusion is that the swelling is more predominant in the subcutaneous tissue rather than in muscle compartment, right? Of course, the latest evidence that I've tried to search in the internet is that there are currently one study going on, I think so, by the Kim Aldi as a PI, which is the bedside ultrasound evaluation and indicators of progression in quarterly snake bites in US. So this I think is more appropriate studies that we can actually look for in the future, which is there are 3 aims in the study, which is the first one, to compare the reliability of the emergency physician or medical toxicologist in the use of focus for soft tissue swelling in cellulitis patient first, because somehow if we want to use the ultrasound, we have to have some credentialing first before we start using it to our patient. And the second aim was to the second aim is to compare the measurement of local tissue swelling from quarterly examination using clinical evaluation and focus evaluation, meaning that they actually describe the clinical evaluation and focus evaluation of measurement of local tissue swelling. So there are 3 objectives in these headings, which is they want to compare the circumferential limb measurement versus focus expansion coefficient. And the second one, they want to compare the progression of proximal leading edge. Proximal leading edge can or cannot be interpreted as RPP because the way they measure is different compared of the RPP measurement, but they compare it as a percent expansion through visual or tactile measurement to focus ultrasound measurement. And the third one, they are comparing the progression of proximal leading edge by percent expansion of swelling using patient's own determination versus the visual or tactile measurement by the doctors versus the focus measurement or ultrasound measurement. And of course, the third one, to establish the inter-rater reliability for the measurement of the soft tissue swelling by the clinical visual tactile evaluation by the doctors and also by focus evaluation. So this is the current studies that are going on. Looking forward to see the results. And of course, when we are talking about the ultrasound, it doesn't actually focus on the soft tissue swelling and also soft tissue edema and also the cobblestone appearance as well. The ultrasound can be used for other things that we want to assess as well, like in this article where ultrasound helps to diagnose the internal bleeding in snap by envenomation, but these are different topics altogether, right? Okay, I think that's all from me. I give back to the moderator. Thank you.
Thank you, Dr. Sabrina. That was a very, very good presentation with current situation where we have a study and also results. So this gives us a deeper understanding of why, or the importance of why we're doing clinical assessment for this patient using ultrasound, because it shows us in our face exactly where the edema is or where the damage is from the envenoming. And this helps us explain the current situation to our colleagues, especially the surgeons, when they already diagnose a patient as impending compartment syndrome or even compartment syndrome, whereby when we put the probe on the patient, you can see the swelling is not in the compartment at all, it's outside, it's in the soft tissue. So the question that we ask is, normally when we show this, are you going to do fasciotomy for a patient with cellulitis, for example? Of course not. But you know, it's just that this really, the visual aid will help us in explaining and also, of course, protecting our patient from unnecessary harm using surgical intervention. So there you go. So I think that was fantastic presentation by Dr. Sabrina. We're going to move on very quickly now to our last presenter, Dr. Chen Xuan Ho. This will be our final and last presentation before we open for QA in our forum. So maybe while waiting, there are a few questions. Maybe Dr. Murad would like to ask our panelists while waiting Dr. Chen Xuan Ho back online. The other two panelists, some of the questions already been asked.
Okay, so I have a questions. Are you guys hear me okay?
Yes, yes.
Okay, right. So the first question will be directed to Dr. Shukruddin. Regarding surgical debridement, what time frame actually we are looking at? So like your case, you presented 9 days. So some clinicians said wait for 4 days, 5 days. So do we have any guidelines on or recommendation actually when do we refer to the orthopedic or the surgical actually team for the debridement?
Okay. So each snake bite cases is unique. So decisions should be tailored to the overall clinical pictures of the patient. But what we advocate is try to avoid going in too early by day 1, day 2, or day 3, because we have to wait for the actual extent of the soft tissue damage. Usually can only be seen by 4 or 5 days of the bite, and it's not that early, because the problem with early intervention is the amount of soft tissue that will excise. So usually the surgeon will underestimate the actual extent, and we try to avoid going in multiple times performing the surgical intervention. And another point that I shared in my slide is post-op complication, which is using of cytotoxic povidone dressing, tight bandaging, that all interferes with the survivability of the potential injured penumbra surrounding the soft tissue necrosis area damaged by the cytotoxic venom. And the rough estimation is by 5 days to 1 week is usual time that we advise surgical intervention should be done in dermonecrosis related to a Najas bite.
Dr. Shukruddin, since we are on that topic, can we actually suggest for the primary team that are actually managing the snake bite, rather than to refer them early to the surgical, because like you said, it's 5 days and it varies sometimes up to even longer. So why not we don't refer them yet, we wait and then we refer later, because sometimes it's actually rather difficult to convince, because you already refer to orthopedic or surgical, and then now you have to convince them actually it's not compartment. So rather than doing that double work, why not you keep them first in your primary care setting, like mostly is the emergency or the medical department or even the pediatric. So we keep them first, and then once we are happy that there's no progression of the dermonecrosis, and then we refer them for the debridement, because that's the current practice that we are doing in Malacca. Yeah. What are your thoughts on that? Yeah.
That will depend on the experience of the managing doctors. Inexperienced doctors, they will have misinterpretation, the soft sign of compartment syndrome, and when they're thinking of impending compartment syndrome, the first thing that comes to their mind is refer ortho, fast. The patient needs fasciotomy. But as we've seen in our REX consultation groups, we try to discourage the managing doctors of referring patient with an impression of impending compartment syndrome. And most of the time we manage to convince them not to go in for fasciotomy. So it all depends on the experience of the managing doctors and how many cases of complicated cases of snake bite has been seen by the managing doctor.
Yeah, I guess that's where the REX actually consultation comes in. So we should advise on that. Yeah, so Prof. Kang, is Dr. Suan Ho is okay with the microphone?
I think he's back in. So let's welcome back Dr. Suan Ho.
Okay, I will present the sonography to detect the intra-compartment pressure. Okay, can everyone hear me? Okay, and in our Taiwan, we have the Necrotizing and the Ultrasonography. In my hospital, the Necrotizing easily make the patient have the acute compartment syndrome. And our surgeon use the clinical diagnosis. The patient has the pain, hair, Fasciitis, paresthesia, and the paralysis to evaluate the patient has the compartment syndrome. In 2014, this is the 57 years old male, and he was bitten by the protoposombus, and the surgeon suggests the fasciitis. As we know, the antivenom is the first choice for the snakebite patient. And if the patient needs the fasciotomy, the compartment syndrome determinant is very important. In the traditional, we use the handheld manometer or use the arterial system to detect the intra-compartment pressure. However, if we can use the sonograph is non-invasive and less expensive. And the most important, we can do the sonograph again and again. This is very suitable for the snakebite patient because their wound has the progressive change. Okay, in 2013, the San Diego, he find that this is the normal person's arterial wave. We can see this is the systolic phase and this is the diastolic phase. If in the simulated compartment syndrome, we can see in the diastolic phase, this arterial wave will become to the retrograde. So we use this finding application in the snakebite patient, and we detect the patient whether he has the retrograde arterial wave. This is the sono on the Doppler signal, and we can see in this color is the target vessel is the radial artery, and we check the Doppler gate and the angle of the insonation inferior to 60 degrees and parallel to the vessel, and then this is the true case. This is the 54 years old male bit by the trimesis stingy. The snake bit over the second and the third toe, and we check the dorsal pedis, and as we can see, the patient did not have any retrograde arterial wave. So in our hospital, we combine two methods to identify the patient's snakebite, whether they have the compartment syndrome. In the mass one, as the speaker mentioned before, we check the cobblestone appearance and we focus the edema location, the edema above or below the fascia. That means if the edema below in the fascia, maybe the patient has the high possibility to develop with the acute compartment syndrome. And we use the method to detect the bitten limb and detect the compression artery, the Doppler signal. In this Doppler signal, we check the diastolic wave and to indirect to reveal the intra-compartment pressure. And I use a video demo to demonstration our sonograph, and this sonograph performed by the Dr. Lee and Dr. Bai. Okay, we use this Philips CX15 and the linear probe with 20 and 25 mini HD. And the method one, we check the cobblestone sign to determine the location of the edema. We slide the probe from distal to proximal. And as we can see, this is the normal pattern. And if the cobblestone sign develop, we can see like this, there are many interstitial fluid. And the most important, we will check the cobblestone sign and the normal tissue. This line, we will mark this this side and can take like the RPP. Okay, if this cobblestone sign in the fascia, maybe the patient have the acute compartment syndrome. And in the method two, we will target the compression artery. First, we identify the artery and then rotate the probe. We can see in this as a pulsatile is the artery, and then we change the probe to the longitudinal plane, and then we will use the Doppler mode. We use the color and and we use the pulse wave to check this arterial wave. And this is a normal person. They take the radial artery, and we can see the systolic phase and the diastolic phase. And if we check in the 21-year-old male, and he was beaten after 7 hours, we can see in this patient's radial artery, there is still no diastolic arterial wave. So we use this combined sonography protocol to localize the inflammation cytotoxic environment, and we can indirectly reflect the intra-compartment pressure. So this combined sonography protocol can help the clinician identify the adequate surgical candidate among patients beaten by the Cotalli. Okay, thank you everyone.
Thank you, Dr. Xuan Ho. That was a very, very interesting advancement in terms of our understanding of the function of ultrasound that we can use for our snakebite patients. So this definitely will help us localize or select patients who having probably suggestive or true compartment syndrome compared to just subcutaneous edema. So obviously this will reflect on how this patient is going to be managed. And of course, in terms of medico-legal as well now, because of technology, we need to prove the reason why we need to perhaps go for a more invasive therapy or treatment. So thank you so much to all three speakers. Now we come to the hot seat session, where some of you already posted question and answer in the QA button here. So you can post your question and answer here. We're going to move to our forum now. I will invite Dr. Yan and Dr. Prof. Yan and also Dr. Reza to moderate the QA session. So we will have about, I think, 30 minutes of QA. So without further delay, I would like to open the floor to our panelists and also our moderators. Thank you.
Yeah, so Dr. Shukruddin, actually, since we were on the topic of many people actually, you know, they get confused with the impending compartment syndrome, where you actually mentioned that it's actually a part of the envenoming syndrome. Just to be on the safe side, what is the real incident of compartment syndrome that we actually get to see with our local species of snake bite? Because I worry sometimes, you know, when you keep on emphasizing that it's not, people tend to look it very lightly, and then we might miss real compartment syndrome. Yeah.
Okay, that's the problem, because most of the hospital do not have striker device or a proper device to measure the compartment pressure inside the patient's limb. Most of the time diagnosis was done with the soft clinical signs, and actually it's not happening only in Malaysia, as I shared in the presentation. Even in America, the decision for the diagnosis of acute compartment syndrome and decision to do fasciotomy is done purely based on clinical judgment. So the actual data, even for our country, we don't have how many cases of snake bite patient with swollen limb truly have a significant elevation of their compartment pressure in the muscle compartment. So it's quite difficult to answer that. But as a general approach of managing patient with a swollen limb, the clinical progression that we have to look into is not only just the compartment pressure, because we have a case last year, I think, involving a child beaten at the foot. Actually, I put it in my slide presentation, but because it comes to a total of almost 50 slides to be completed within 20 minutes, so I have to delete the slides. Actually, I have the slides where actual compartment pressure was done to the patient using modified white side technique. And we noticed that the compartment pressure ranges between 70 to 90 millimeter mercury, which is quite significantly elevated. But when we look to the clinical signs of the patient, the pain score at that point, the rate of swelling progression is not progressing. The pain score was 0 at rest, only 4 on manipulation of the beaten limb, and the creatinine kinase has plateaued, which is the level is not increasing. So the decision at that time, even with the elevated compartment pressure, fasciotomy was not performed to the patient, and no adverse outcome came to the patient. So the patient went through a good outcome without any invasive surgical intervention or fasciotomy. So we have to look the patient as a whole before making decision, and we have to look at all the clinical parameters that's available to us, not just one parameter. It's not meaning that all patients with intracompartment pressure of 40, if you follow the WHO Southeast Asia guideline, must be performed fasciotomy. No, decision must be based on the whole clinical picture of the patient, and what is the response of the patient towards antivenom treatment. That's the first line treatment that we should consider instead of early surgical intervention.
Okay, I have the second question to Dr. Ruth. Okay, people are actually excited, or they want to know if they get bitten on the head and the scalp, how actually measure your RPP, and some actually do raise a point that they want to use a marker pen and do a circumferential marking on the scalp so that they actually can monitor. So I think people are getting a little bit confused here. They are obsessed with the marking, you know, and then they want to solely based on one parameters like the RPP. Maybe you can clarify further on this. Thank you.
With regards to the first question, if the patient was bitten but on the head or at the scalp region, so it will be a bit difficult to actually measure the RPP, right? At that particular point of time, maybe we should actually observe the extension to which extent rather than actually using the RPP, because sincerely speaking, for the head and neck region, it's really difficult to actually measure the RPP. The second question is regarding
using marker pen, marker pen on the bite side.
In Malaysia, through our consultation, we will try to avoid to suggest to label or to mark the extension of the swelling with the marker pen, because sometimes for example, it can actually obscure the necrosis extension. So we didn't actually recommend the use of marker pen.
Okay, and then there's two more questions for you, Dr. Ruth. One is actually participant, actually they would like to know the level of increment in the RPP, meaning what's the significant value. And the second question will be, how do you interpret the RPP that you measure using ultrasound? And then some actually participants were asking whether there's some percentage that you want to look at. And some even say, why not, rather than referring to a surgical team for debridement, can we refer to a sonologist so that, you know, you can get the extent of the expansion of the edema, or whether or not it's actually a compartment that, yeah. So there are three questions for you then.
Okay, so regarding the RPP, so the rate is measured in centimeter per hour. So when we say it's centimeter per hour, means that we are measuring the rate whether it's actually static, increasing in a static way, or actually increasing in a very rapid way. So of course, as I mentioned before, the RPP is should be interpreted together with other clinical parameters for local envenomation, and it actually does not carry weight as the RPP per se. So to determine whether how fast is considered as fast. So that's why you have to measure the RPP if the patient is just bitten by a snake bite. So we have to closely monitor the RPP as frequent as hourly, because in a few hours the patient was in ED, we can actually determine whether the rate is increasing or static or decreasing, so that we can actually decide whether we can actually give the antivenom or not for this patient. But of course, again, depends on our emergency department setting, whether you have got a good observation ward or not. I cannot say for any emergency department. I cannot say for other emergency department, but it is best if we can actually observe the patient for a few hours in emergency department, so that we can do these things at least to determine whether the patient needs antivenom or not for the local envenomation.
Right. And then just to answer regarding referral to a sonologist, I think the report will be to correlate clinically, so you know that it's not going to be helpful. Okay, the next question will be to Dr. Suan Ho. Let me read the question for you. Okay, is your ultrasound measurement of intra-compartment correlate with specific measurement of intra-compartment via any device? Meaning, I think the participant is asking whether the ultrasound is actually being compared to the other modalities of measuring the intra-compartment pressure. Is there any correlation or being proven? Yeah. Please, Dr. Suan Ho. Yeah.
In our hospital, hello, can you hear me?
Yeah, go.
In our hospital, we did not compare the sonography with actually the traditional compartment pressure measurement. But in the 2023 that article, they also compare the method to show and to realize this Doppler signal has the very accurately revealed the intra-compartment pressure. And in our hospital, as we say, from 2017 until now, we applied the sonography in our snakebite patient, and there was no one received the fasciotomy, and they did not have any adverse effect until now. Okay.
Let me pose the next questions. A participant actually would like to know whether any of us actually work on sea snakes, venomous sea snakes and cobra, or terrestrial snakes are having similar kind of venom. Yeah, I think this one I'll open to any of the panelists actually who will be willing to answer. So meaning the difference between the sea snake, our terrestrial snakes, yeah, any difference there?
Maybe Prof. Mao can answer this.
The sea snake, we don't have the sea snake bite, but I know some venom component of the sea snake. It is myotoxic, neurotoxic, maybe very difficult to treat.
Yeah, I just can add on to that we do have in Malaysia did some, especially from University Malaya team, studied on the toxinology of the sea snake venom, and also the effectiveness towards the antivenom. The difference is that sea snake is highly cytotoxic in nature. It's neurotoxic in nature, that it causes very little tissue necrosis. So that's not much cytotoxicity compared to, for example, the close cousin in the elapids, which is the cobras. which cause massive cytotoxic effect. So there's a difference between the two groups of snakes, even though in terms of family they belong to elapids, but the sea snake, in terms of the venom, is slightly less complex compared to the cobras. So yeah, I think that should answer the question. And we do have antivenom for sea snake in Malaysia, which we imported from the only producer in the world for sea snake antivenom, which is from Securus, Australia.
Okay, Dr. Shukruddin, I have some question. Thank you for your presentation. You mentioned about dermal necrosis, right? It is quite different from necrotizing fasciitis. But in your picture, we see after debridement, the damage is very deep into the fascia layer. So we know skin can be divided into subcutaneous fat and fascia and muscle. Although your patient have a good muscle, the muscle is red, viable, but the fascia is removed. I think the damage is very deep, not just the skin necrosis, right? So because necrotizing fasciitis is a surgical diagnosis, so I think your case is maybe some form of necrotizing fasciitis, maybe local form, not extensive form, right? Repeat the question.
Repeat the end part of the question.
Okay, okay. In your picture, I see the damage is very deep into the fascia layer after debridement, right? But you say dermal necrosis is not necrotizing fasciitis, but necrotizing fasciitis is a surgical diagnosis. I mean, in your cases, the fascia was removed. It is damaged. It was damaged. So we can say it is a local form of necrotizing fasciitis rather than dermal necrosis, right?
Okay. So the definition of necrotizing fasciitis, if we go looking for the definition, usually it is related to infective cause and aggressive soft tissue infection, which is primarily because of infective cause. But in tissue necrosis due to cytotoxic venom effect that follows some of the Naja species snake bite, the damage is not primarily because of infection. It is because of the cytotoxic venom effect. Of course, sometimes when we send culture and sensitivity of the debrided tissue, the bulle, it do not mean that the infection is causing all the damage. Because majority of cases that we see, we do not culture any significant bacterial from the necrosis tissue, which means that most of the damage primarily because of the cytotoxic venom effect, not because of the infection that is causing the damage to the soft tissue. And the extent of how deep the necrosis will occur will depend on the specific effect of all the enzymatic function of the venom itself. So what we try to avoid is when the managing doctor is putting necrotizing fasciitis as the working diagnosis, it will affect the clinical management, because when we look for what are the recommended treatment for necrotizing fasciitis is early debridement of the infected tissue. And you have to debride quite extensive because the soft tissue is infected. But different from necrosis because of the primary venom effect, we try to salvage as much as possible the viable surviving tissue because they have a potential to recover. So the diagnosis that we put on the patient's note will affect the clinical management plan of the patient. That's what I emphasize of try to avoiding putting necrotizing fasciitis as the diagnosis, because it is related to it is mainly because of infective component of the diagnosis. compared to putting as venom necrosis as the working diagnosis, because it affects the clinical management plan of the patient.
Thank you. Because I have do many deep tissue biopsy culture, and the cultural results show bacterial infection after deployment, especially in the fascia or adipose level. So I think the bacteria invade into this tissue, compatible with necrotizing fasciitis or necrotizing adipositis, if the damage is not deep into the fascia level, but limit to the subcutaneous fat. We will say necrotizing adipositis, but not just the skin necrosis, because skin is very thin. In Taiwan, the natural atrophy bite usually involved adipose tissue and fascia level, and we culture the fascia and the adipose level show many bacteria. So can I ask what antibiotic selection will you choose for nausea bite? Thank you.
Usually, the commonest antibiotic that we use is augmentin, amoxicillin, and clavulanic acid. Sometimes unacin is used to cover the possible invading possible infection or secondary. Mainly our concern is towards secondary bacterial infection. And some of the cases the culture came back as Morganella species. We have one cases came back over as Shewanella species. That's a few of the bacterial that were isolated from the wound of the patient with the necrosis.
Thank you.
Prof. Carl, actually, I have one debatable question for you. Let me get it. Okay, so a question from our participant stated that Rex tried to reduce unnecessary surgical intervention. The question is there any mortality, morbidity associated with the practice of delaying the surgical management? And who should be the decision maker for medical versus ortho approach? Is Rex consultation valid in court? Prof. Kang?
Yeah, okay. So thank you so much. That's a very good question, because the reason why we are doing this is actually to highlight why we should actually look at managing patient with evidence. So far that we from Rex experience, we have seen about thousands of you in the past few years, thousands of consultation, and no patient died directly because patient was consulted to Rex. Okay, so that's one. Second, we reduced the number of unnecessary fasciotomy for patient, and as Dr. Swanho said, since they're able to show that the problem is not in the fascia, therefore patient doesn't have to go for fasciotomy. So we already seeing that. And the question is that whether what do you call the question just now about medical legal, right?
Medical legal, yes.
Yeah. So no, the thing is that Rex is a very how should I say, pro patient and also pro outcome of the patient. So we provide advice. So Rex cannot be the primary managing doctor. We are called because there's uncertainty in certain facts or uncertainty in managing patients. So we provide that advice based on our experience, based on what's available as evidence out there. So it's up to the doctor, the primary doctor managing the patient, to take that advice and put that into their consideration. So we can't say, oh, please don't do this, please don't, do not do this or do not do that. Please do not do this because of this. So that's the evidence that we provide. And over the years, we can see that there's a change in the modus operandi of our colleagues in surgery, where they say to the doctor, please call Rex first, rather than consult to them directly. So call Rex first, see what did they say. And this is actually a very, very interesting shift on the paradigm shift of how our colleagues, medical colleagues are thinking, because they say, oh, look, if the patient can be, managed without any surgical intervention, why not? It saves us time, saves us the trouble, saves costs in the end as well. So this is where we come in as a advocate for patients, and also to support our colleagues, and also indirectly will be reducing costs in the end. So this is a positive step, I think, and this is where REX is rather unique in its existence in Malaysia, and perhaps also going to be in ASEAN region, because REX is now expanded for ASEAN, REX ASEAN. And soon we will probably have a clinical toxinology fellowship also based in ASEAN. So yeah, so I think that should be answering the question, I think. Or not?
I believe, yeah, I believe it does. It should be able to, yeah. Okay, to Dr. Swan Ho, can the Doppler be used for all snake bite cases, or it is used for snake bite with compartment syndrome? So I think the participants are a little bit, I mean, the question is being imposed frequently. So yeah, Dr. Swan Ho. Is it advisable to do it in all the snake bite patients, or certain patients that you actually select to do this ultrasound?
In my hospital, the result of this study is suitable for the Necrotizing snake bite. But if someone can promote this solo method to all snake bite, I think maybe we can see many different results, because from the elepidi, including the Naja and including the sea snake, maybe the necrosis wound presentation is very common in this patient, and the swelling is common in the patient bitten by the Necrotizing. So until now, these two methods cannot answer where what the patient will develop as the necrosis wound change. As I know, there are some specific sonography finding in the necrosis. So maybe we can add the method third for the necrosis sonography detecting. So maybe when we combine three methods, we can apply in all snake bite. Okay.
Probably for the symptomatic local patient, when patient come without any local symptoms of swelling and so on, probably there will not be any real need for ultrasound, I think.
Right, and then let me get this to Dr. Ruth. Elevation of the limb with the snake bite. The question is, will it affect the accuracy of your RPP? And is limb elevation recommended?
Probably. But I will say that during the initial phase, limb elevation, significant limb elevation may not be needed. Just put the limb in a neutral position with slight limb elevation will do.
So slight, like how, I mean, I'm sure the participant was, how slight is slight, or how
slight is slight
of extreme, yeah.
Okay, I think I open to other Rex to answer that. How slight is slight. There's no like such thing as elevation of more than 45 degrees or whatever. So it's just a slight elevation will do.
So I think it's elevation is just very subjective as well. So how high is high, and like your RPP, how fast is fast. So what we see is that if you raise the edematosis still in swelling stage, raise it too high, above the heart level, where the patient position is, it might actually cause the edema in the distal part to worsen and also block the blood flow. So it's a counterproductive in terms of this. This is from the snake bite injury. So what you need is actually a position where at least the arterial blood can pass through the edema into the capillaries and also return back in the venous and also from the lymphatics. So if you raise it too high, some of these dynamics can be affected, and therefore it makes the swelling worsen. So that is actually, I think, documented in the WHO guideline as well. So you can have a look at the WHO guideline and explaining these particular dynamics in a bit more detail. So we recommend just elevation, not over excessive, it's just to the level of the heart level where that's where the systolic is good, the return is also quite neutral. So that's it. Yeah.
Okay. This one I will open to all our panelists. From my reading that I've gathered so far, there's actually quite a high adverse reaction towards antivenom that being reported at Sri Lanka as well as India and even Thailand. But from what I'm seeing, maybe because of my limited experience, that our patient is actually not that bad, you know. So they don't develop that much of reaction towards our antivenom. So yeah, any thoughts on that? Dr.
Maybe Taiwan can answer about antivenom because they are producing antivenom.
Yeah, Dr. Sanho, yeah, would you be? Yeah.
Okay, in our Taiwan, we have very high quality antivenom, and we have two kinds of antivenom, one kind for the Necrotizing and another for the Elepidine. We also choose specific antivenom for the other, like the chain snake and the 100 pies heat. And in my country, the antivenom is provided by our government, and our clinician can use the antivenom by the patient clinical condition. But because the antivenom is difficult to produce, so our government give this antivenom in some hospital. Not every hospital. They based on the epidemiology of the snake bite, and our government will choose the most encountered antivenom in this hospital. And maybe the more detail we can let Dr. Mao to tell us.
Maybe Dr. Shuk want to talk about Malaysian experience about antivenom and hypersensitivity reaction.
Yeah.
Okay. For Malaysia, we are using a lot of antivenom produced by QSMI Thailand for our local snakebite victims, because we have closely related indigenous snake species with our neighbor Thailand. And yes, occasionally we are seeing some form of reaction, but majority of patients who may develop reaction, mainly most of them develop dermatological type of reaction of urticaria, rashes. And when this happen, usually we advocate for the patient, for the treating doctors to stop and give treatment of steroids and antihistamine. And then still, because the patient is clinically indicated to be given the antivenom, we will restart after the symptoms improve and no life-threatening adverse anaphylactic effect of the patient has occurred. We still advise for the antivenom to be restarted with very close hemodynamic and clinical monitoring of the patient, and usually at a much slower rate of infusion. And we have a recommendation rate of giving the standard recommendation rate of giving antivenom to the patient. And it is if you search for literature, sometimes the adverse reaction occur sometimes because of how fast and how much antivenom was given. If you are giving it too rapid, it can invoke some form of allergy reaction. As we know, antivenom is for Malaysian that we use Thailand QSMI antivenom. It is produced from horse's serum. So it has potential to cause an allergic reaction because it is not a human antibody. And yes, we are seeing, but most of the allergy reaction is not life-threatening.
Okay, can I just share that WHO in their second guideline that they came up in 2017, if not mistaken, they actually recommend the use of prophylactic adrenaline subcutaneous based on the Sri Lanka study. And we are not actually being practicing that. Well, I assume because of our lower adverse reaction that we have from our antivenom. So, Prof. Karl, would you like to make a comment just in case the participant actually, you know, when they read the second guideline by WHO, and then they say it's stated there that it is actually recommended to routinely use this prophylactic subcutaneous adrenaline. Yeah.
Yeah, so that you have to look at where the antivenom is produced, from what method of manufacturing. So there are different qualities of actually manufacturing antivenom, how it's prepared, is it in liquid form, is it in a powdered form, so contamination issues. So all these things come into play. So it's not one bullet for all. So basically, for us, I think because of in Malaysia, the medical system is probably well developed, and our doctors are well trained in managing allergic reaction, go down to anaphylaxis. I think this prophylactically applying drugs or medication, is going out of favor. So for us, we treat as the disease develop. Because we are rather fast in intervention, and we are rather well trained in doing so, and it is shown in our outcome of how we manage our patients as well. So we see that so far no patient died of really anaphylactic reaction or anaphylaxis from or anaphylactoid reaction actually from snakebite envenoming in Malaysia. So far, that was referred to Rex. Okay, we can only say
on that matter. The same guideline actually recommend that we should be very aggressive in treating the allergic reaction. I mean, the moment there's any skin findings, that was from the WHO. Yeah. So which I think we are not being that aggressive. You know, like I assume maybe because our adverse reaction was actually lower compared to the other countries.
It's not just lower, it's actually that's why in everything we always request for close serial observation. When you are actually administering, you cannot leave the patient with the monitor. You have to be beside the patient and look at all the signs. And as Dr. Schut said, as these things arise, we already withhold and we give, and we find that after every maybe 5-15 minutes the symptoms will resolve, as if like you were giving for example pethidine to patient in the OT. You get some skin reaction, you give the antihistamine, so it resolves. So it doesn't mean that when it starts as an allergic reaction, it will continue on as an all or none effect to go into anaphylaxis. So that is not how it goes. So for us, I think we should decide on aggressive. I'm not really sure what you mean by aggressive by doing early. To me, if somebody do a prophylaxis because they're afraid of something, it just reflects on how good they are in managing a patient. So that's just a personal view, I think.
Dr. Ruth, this question creep up a few times, so let me direct it to you. Venom ophthalmia alone, ini just pure venom ophthalmia. Any indication for topical antibiotics and our anti-tetanus toxoid? So this question came up at least few times here.
For us, actually, it depends. Okay, for venom ophthalmia, so if there's any any abrasions or all that, I will give ADT as well. For topical antibiotics, I think we will not give in ED, so it will be the jurisdiction by our ophthalmology team whether they want to give antibiotics or not. Yeah.
Okay, all right.
I think it's
So,
1:31 already, so
yeah,
you can spare a few more minutes.
Yeah,
just
I
finishing off.
think yeah, one more last questions to our panelists. I open it up. I think the participants are a little bit confused, you know, because the participant is asking is by anonymous attendee that why we are not advised to give steroid or antihistamine as prophylaxis in snake bite cases. Is all patient unknown bite need to be observed for 24 hours as mentioned in the CPG, or there's any rule of like 6 hours observation? So what's the longest onset of animation that may occur? So actually 3 questions there. Why not giving prophylactic steroid and antihistamine? And why with unknown bite you observe longer for 24 hours? Second question. Third, why not make it shorter? Because I think in most of our patients in ED setting, we observe them for 6 hours, and if nothing happens, we let them go back. Yeah. So the first one, Doctor, can I pass it to Dr. Swan Ho? Why not giving prophylactic steroid and antihistamine in snake bite?
There is article suggests no antivalent and no steroid before the antivalent. But if, just like the question, if the patient may have developed the anaphylactic shock, so maybe some antihistamine or the steroid maybe is okay for this patient.
So yeah, if there is evidence of anaphylaxis, then of course we give, but we don't give prophylactically in any our snake bite patient. So question number 2.
Just to clarify on that, even though this is not related to ultrasound, but why not just give everybody antihistamine and steroid? Because this is not like, as you know, everybody going to develop allergic reaction for a snake bite. For you to understand why we give a prophylaxis, because maybe somebody has already been hypersensitized to external protein, for example, venom or some of the snake products. Okay, for example, if you are allergic to bee sting known and you're wearing a bracelet, then that's why you carry your EpiPen, but not for snake bite. So not everybody has been sensitized by snake or snake proteins in the past, unless somebody has been working very, very closely with snakes and exposed to the vaporized feces and urine, for example, and also the skin shedding. So they are being hypersensitized already. Yes, these people may actually, you know, develop allergic reaction, but not in general public. All of us are actually allergic to, will develop allergy to snakes or snake bite.
Okay, I say something about steroid and antihistamine. The venom component induce swelling, not related to allergy. So in some animal study, steroid and antihistamine can reduce the swelling, but not treatment for the urge. So far as I know, I didn't see any paper regarding steroid or antihistamine in the treatment of snake bite in a controlled study. I didn't see any paper, but in animal study, this drug did used for swelling treatment.
Dr. Ruth, I think we have time for the last question. Why observe them 24 hours if you have unidentified snake bite? And why not 6 hours? Yeah, I think let's make that as the last questions, as we actually way past 1:30.
So basically, in an unknown bite means it is not necessarily snake bite, I assume. It may be snake. So the 24 hours rule is actually introduced because some of the venom, some of the snakes that can manifest, the venom can manifest actually after 24 after, even after 48 hours, especially if we are talking about the pit viper envenomation. If the patient is actually being bitten by a possible neurotoxic snakes, for example, we can possibly have the symptoms actually being observed quite early, rather than actually being bitten by the pit viper and have some minimal local tissue swelling. That is the necessity of the observation. So even if you discharge the patient, so by right, the patient should have the follow-up to monitor the signs and also the symptoms.
Okay. So Prof. Kam, do you think we pass it to you now?
So yeah, I think Dr. Ruth answered it, but you have to understand, you have to look at what is there, the species of snake in your area. Different country has different snakes, and therefore they will have different effect on the human body. So we normally will the criteria that we use is actually whether it is potentially dangerous or potentially not dangerous or potentially deadly. So these are the things that has to be at the back of your mind when you're managing patients with snake bite, is to know what is in your community, what is in your country, and how these snakes can affect humans. Okay, so this is why we are having this discussion here, and that's where close serial observation is in place for us to see whether this patient will develop certain signs and symptoms. This is what we call syndromic approach, and there's a different country will have a different set of flow of the syndromic approach to identify what type of species of snake, not even to the species of snake, what type of symptoms that can happen based on unidentified snake, okay, or unidentified cause of injury, for example. Okay, so this is about safety issues. 6 hours is maybe the earliest that, for example, certain crotaline snake bite can appear, or even some of the elapid, for example, the crates, they can present quite early. And without significant local tissue swelling or pain. So a close observation is where we look at all these parameters closely and serially. So we don't want to miss these patients. Some people say, oh, why don't we put in ICU? ICU is, very very sophisticated in close monitoring. Well, it all depends on where your critical care extension is. So if it is in the emergency department, 6 hours observation is fine. But if there is no sign or symptom, really, that's where in the consultation to REX, some patient may not stay 24 hours after bite. So we know that if there's no swelling, there's no pain, no typical features of secondary infection setting in, yes, this patient can go home and maybe to come back when there is some other signs. But that decision must be, I always say, verified by qualified people. So that's where we also come in to help doctor make that decision. Okay, is that okay, Reza? Okay. Okay, so shall we close the session? Thank you so much to all speakers, and also to all moderators, and especially also to all participants. We had quite a good attendees during this Saturday afternoon. I'm really, really happy to see there's some participants from all over the world, actually. We will put this up, and this is going to be recorded, so you can always come back and view this video in our Facebook live. Will be recorded and will be played over whenever you are on demand. Okay, so this session is also going to provide e-certificate. So please make sure that you register your name correctly, because we're going to issue the e-certificate for all participants. And also we provide CPD points for this particular webinar. We have 2 CPD points from our National Medical Association. So you can actually register your CPD point with them. And just that the certificate will be a bit delayed, maybe a few weeks to reach you. So make sure your email is correct and your name is correct when you are registering. Okay, so there will be a Google form registration also, if I'm not mistaken. Mr. Samsul will actually our technician will probably give you the online Google form for registration. Okay, so with that, I would say again, thank you so much for being with us, and hopefully we'll see you again in another session. We will have a few about snake bites and its management, snake bite injury, now we call it SRI, snake-related injuries, to discuss, because we're not just dealing with bites and envenoming. There are snakes that can cause, for example, just now, venom ophthalmia came up. That's another type of injury that it's not a bite. Okay, so with that, I thank you. Have a good weekend and take care. Keep safe. Right. Bye bye.